Body.
body, systemic. You're gonna have those systemic signs and symptoms. Okay, left-sided, think about lungs, decreased cardiac output, right side is systemic. Okay, is that what you had on your paper?
Mm.
Okay. All right, jugular vein distension. Do we see the jugular vein distension up here?
Yes.
Yes.
What is that telling me? Left-sided or right-sided heart failure?
Right.
Right-sided, right? Because the blood is backing up into the body. Okay, that's what we check. Jugular vein distension. Frothy pink tinge sputum.
Left.
Left. Because the blood's in the lungs.
Is it the left side?
Mhm.
Yes. Right? Have you ever seen frothy pink tinge sputum? There it is. I always think about it as, you guys have had this before, right? If you've ever gone to a church dinner,
Yeah, no
it's
position.
the strawberry.
That way I can just see your face and turn the chair this way.
That,
Okay.
that's what frothy pink sputum is. So left side, right? We got blood back in, pulmonary edema.
Never did that.
Never did that again.
Okay.
Let's see if this works.
Mhm.
Okay, S3 heart sound. Extra heart sound.
Oh,
You're fine.
Mm. Oh, oh, and we're back.
Normal in young children, pregnancy, athletes, but this is a sign and symptom of heart failure. Left or right? Usually left-sided. Okay? So listen here. Hear that?
Mm-hmm.
After the S2, lift up. But Kentucky, they always say Kentucky, right? It's Kentucky. It's that sound you're gonna hear right after the second heart sound. What's that? Wisconsin?
Now,
Yes.
from a tariff war, as
Oh.
we discussed earlier in the program, and tax cuts for the rich, is there a method when it comes to MAGA?
So extra hard sound can be normal, young, athletes, but could it be a sign and symptom of heart failure?
Yes.
Yes, left-sided, okay? Weight gain. Who's gonna be weight gain?
Right side.
Right-sided, okay? Blood is backing up into the body. Okay, weak peripheral pulses. Left or right?
Right.
Left or right?
Left.
Left, right? Why? What did
Oh,
we
because
say?
the blood's not getting out to the
The
bottom.
blood, the left ventricle is not pumping it out to the body, right? So we have poor perfusion. Right? Our pulses are gonna be weak. Dependent edema,
Right.
Right.
right-sided, right? Systemic congestion.
Left.
Left side.
Oh,
Crackle.
Sorry.
Does it sound like?
somebody blowing into a microphone.
Yeah, it does sound like someone blowing into a microphone. Good, wood burning in a fireplace, kind of crackling sound there. Some people say it's like Rice Krispies, some people say it's like rubbing your hair in your ear there.
Yeah.
What is that telling me? Crackle. That's your- That's your client, so we said left side, right?
Yes.
Okay, how about anorexia and nausea?
Left.
Right.
Right side, why?
Work because rest of the body, systemic.
Systemic, right? Extra fluid there, can get into the liver, anorexia, nausea. Okay, good. Okay, so left side, we're discussing decreased cardiac output and lungs. Yes?
Mhm.
Causes, right? We talked about possibly a patient with an MI. Okay, a dysrhythmia. Valve disease, all of that can cause heart failure. As we age, okay? So we have decreased cardiac output, decreased or increased pulmonary congestion. Okay? A life-threatening event that can happen is pulmonary edema. What's happening in pulmonary edema? Pulmonary. One in the lungs, right? Left ventricle can't pump like it should. So we have increased pressure that's building up in those capillaries. Yes, what did we say? It's that frothy pink sputum, right? Fluid is gonna leak across those pulmonary capillaries, into those lung tissues. So think about a patient can't breathe, right? They're gonna be anxious, cyanotic, use of accessory muscles, tachypnic, pink frothy sputum. What do you think you would do for a client who has pulmonary edema? Fluid overload, diuretics, right? And get rid of that diuretics. Right? What would be something, what diuretic could be used? Furosemide is a common one, yep. Okay. Sometimes they'll give morphine to a client, right? The patient's not in pain though. Why would we give morphine?
Relax.
Relaxation, right? So that respiration rate down, right? Decrease the work of breathing. And then right-sided, we said, if that starts to fail, then we have systemic congestion. So it's gonna back up into the venous system. So weight gain, lower leg edema, nausea, vomiting, JVD, okay? What's gonna happen to our blood pressure? You think it'll go up if we have all this extra fluid?
Yes.
Right. Here's an example of pitting edema. Have you guys seen pitting edema?
Yes.
Yeah, lower extremity pitting edema. So you would monitor that and you would also assess it. How would you grade pitting edema? Plus one, grade 2, 3, 4. Yeah, non-pitting or pitting. Yeah, good. Okay. Can a patient have mixed, meaning can they have left and right-sided heart failure?
Yes.
Yes. Okay, so we might have a mixture of those symptoms. Okay, usually starts out as left, but it can affect the right side too. Poor ejection fraction, less than 35%. What do we say is normal? 55 to 70. Okay, so you might have mixed symptoms. So think about your patient that you cared for with heart failure. Okay. Why might these ventricles become enlarged in a client who has heart failure? Yeah, why does it become enlarged? Why do you think the heart muscle becomes enlarged? It's working harder, right? It has to work hard. Remember we talked about it being a muscle, and the more you work a muscle, the bigger it gets. Okay, so you could have enlarged ventricles. Is that good though?
No.
What do we talk about? We have hypertrophy. Does that mean that we have more cardiac output? No, right? Because the ventricles are going to be larger, but it doesn't mean that they're going to pump as well. That heart rate is not going to pump as well. These are just pictures of enlarged ventricles and also thickened heart muscle, right, that we talked about. All right, let's talk about BNP. Remember that one that we talked about, that lab? Brain natriuretic peptides. When are those elevated? Heart failure. Do you remember how we talked about normals? Remember 100? Or was it 900? I can't remember.
Severity of the heart failure.
What do you see for BNP? When you guys see a patient with heart failure, how high is it? Anybody seen a BNP?
Thousands.
Have you seen thousands?
Yes.
Okay, clinical, right? We have patients in the thousands. Okay? What normally happens in a healthy heart? Right? For BNP, counteracts the RAS system. What did the RAS system do? What was the whole point of renin being released? Increase the blood pressure, right? We're gonna hold on to extra fluid to increase the blood pressure, right? That's why renin is released. Okay, it counteracts it. So what should it be doing? Yeah, it should be getting rid of extra urine, right? But if you have a heart that's failing, is it gonna be able to do that?
Mm-mm.
No. Okay. So you're gonna have an elevated BNP. Gonna show you the severity of a patient with heart failure. Okay. You might have a patient who comes into the hospital with a heart failure exacerbation. Have you had that? What does exacerbation mean? Worsening of symptoms, right? Patients can live with heart failure. Okay. What's client care? How do we care for a patient? What do we teach a patient who has heart failure? Low sodium diet. Okay, what do you know about sodium? If we eat a lot of sodium, what follows it?
Water.
Water. Okay, if we have a lot of that, we're gonna retain water. Extra fluid. Is that gonna be good for the heart?
No.
No. Okay, what else would you teach a client? What'd you say? Compliant with meds. What meds do you think they're gonna be on? Yeah, might be on a beta blocker, ACE inhibitor, diuretic, right? Compliant. What would you teach them?
Weigh themselves every day.
Okay, with the medications.
Oh.
How do you compliant? A schedule. Take them.
Take full dose.
As
Full
directed.
doses every day as prescribed, right? Okay. What about, what did you say, Courtney?
Checking your weight.
Checking your weight. When should the weight be done?
In the
Every
morning.
morning.
Same clothes.
Same
Clothes.
scale, same clothes, or not clothes, right? Whatever you do, it has to be consistent. Good. What else would you teach a client who has heart failure?
Smoking.
Okay, if they smoke, yeah, we want to smoke. Not smoke, we don't want to smoke. Okay. What else should they be doing? Okay, edema, they might need to wear some head hose, yeah. What else should we all be doing every day? Diet
Exercise.
and exercise, right? Good diet, low sodium, veggies, fruits, right? Exercise daily. Take your meds. What happens if the patient starts to have different symptoms? They become more short of breath, they're gaining weight.
Contact your health provider.
Contact your health provider, right? This patient might need to have their medications adjusted, or their education needs to be done about taking them, or diet. But if you have a patient who comes in with an exacerbation, what would be some things that you would do if a patient came in with an exacerbation of heart failure? They're really short of breath,
Oxygen.
had the bed up, I heard oxygen. What do you usually give them? Diuretics, how, what route? IV, right? We're gonna give them IV. That's gonna get rid of that extra fluid. Good job. Okay? Oxygen, make sure that they're taking their medications. Good. All right. Who are my Grey's Anatomy fans? All right, what was his name that had the LVAD? Denny. Denny, yeah, Denny.
Don't cut the wire.
Don't cut the wire, right? Okay, so this is a left ventricular assist device or an LVAD, right? This might be something a patient has at the end stage heart failure, okay? What is the point of an LVAD? What does it do?
Helps contract.
Right, it works like a left ventricle, right? When your left ventricle is failing, you're not able to pump, a patient can have an LVAD. right, implanted here to help.
Thanks, Hillary.
You're
Thank you.
welcome. Thanks, guys.
Thank you.
Good job. Thanks for kind of smiling. Courtney.
I didn't smile to my
I am.
close up. He was like, can I move your computer? And I'm like,
The mechanical pump is implanted, right? It works just like the heart would work. Good. There's left side that's right sitting available. Okay, you gotta be hooked up to like this generator thing, and then we got battery, so I'll make sure that battery's full, we have an extra battery. Yes, and what did, I don't even remember the lady's name.
Izzy.
Izzy, she cut the wire to do what? So he did a transplant, right? He died. I don't know.
Yeah.
I think that's when I stopped watching. It's still on, isn't it?
Yes.
7 seasons later.
It's just like 20.
Like 17. It just needs to stop.
It needs to stop.
It was good.
Yes, it was good to start with, but then too many seasons.
Rewatch that. Okay, so this could be a lifelong, or it could be called, what do they call it, bridge to transplant. Meaning that they'll have this until they can find a heart transplant. So it might just be kind of a lifelong thing or a bridge to transplant. And then, of course, there is that heart transplant, right? The patient might need a heart transplant. We're not gonna talk about that though, but the information in there. Anybody works transplant, that'd be pretty interesting, anybody wants to do that, but that would be an intervention, right? For clients if their heart is failing. All right, questions on heart failure? Left side,
Yeah.
lungs, decreased cardiac output, right side,
Systemic.
stomach. Should you know signs and symptoms?
Most
That would
definitely.
be a wonderful select all apply question.
Oh, God.
1 minute. I can probably guarantee you're gonna see that question on the test. Yes,
Is, Laura showing you the number both?
usually it's right, because it's systemic. So,
Could-
yes,
Could weight gain be both though, since the fluid overload in the lungs?
possibly, yeah. I'll make it very, it's
Okay.
a great chart here, but I would guarantee it's gonna be on. That is a give me question. Everybody should get that one right,
Mm.
right?
Challenge accepted.
Challenge accepted.
No, you just.
What happens if you don't get it all right? Well, then what is the consequence?
You're gonna take where?
Yes, we are. Your birthday, is that what you said? We'll get ready for you. All right,
You're gonna give us an all passing grade if we all get it right.
you know, I'm gonna have to get to you, you're just gonna earn it. All right, heart failure, another complication of an MI. Let's talk about some valve disorders. Heart valves, okay? Just real briefly on heart valves, right? With heart valves, there can be stenosis. And I have a picture there of aortic stenosis, which is probably the most common that valve dysfunction you'll see. What happens with stenosis? Kind of narrows, right? So you have a picture of an open, normal aortic valve, and then what do you notice here? Definitely have some stenosis, right? Abnormal narrowing. Look at that when it's closed.
It doesn't
Is it
close all the way.
100% closed? Okay, so what happens then? If that valve is not closed 100%, is there blood that can still move back and forth?
Yes.
Yeah, what's that called? When you can hear that kind of swishing under a valve. Murmur. Have you heard a murmur?
Mm.
Yeah, when those valves are incompetent, they're not closing properly. You hear kind of that swishing sound, that murmur. Okay, you can also have the valves that can have some regurgitation. What does that mean?
Comes back.
Yeah, insufficiency again, doesn't close completely, so you have some of that blood back, and then a prolapse. This is when those leaflets can enlarge and kind of protrude into the heart center. Okay, all abnormal, right? Can all cause problems. How do you think we would look at the heart valve? What would be a task that we would do? Yeah,
Okay.
your echocardiogram, yeah, if your echo is gonna be a good one to look at, the valves and how well, if they're closing properly, if there's any prolapse or stenosis. So over time, what can happen, especially when you have aortic stenosis? What's that? Can become blocked, yeah, and then what else happens if that valve is not being closing properly all the way? How does the heart compensate? Yeah, you might have some hypertrophy of that ventricle that starts to kind of help to pump that extra blood through, yeah. Might have some pulmonary congestion, right, if that valve isn't able to close on the left side. So kind of, as they say, I think they call the aortic stenosis kind of wear and tear. It's normal over time as you age. And you might have some changes to that aortic valve. Okay, so non-surgical management. How would we treat a valve that maybe isn't functioning correctly? And non-surgical.
Medications.
Yeah, medications, right? Because patient could have some heart failure, right? If we've got some blood backing up, the heart's not bumping as well, we can have some heart failure. And what did we talk about with some signs or some medications for heart failure? Diuretics. Think about the meds that we talk about all the time.
Beta blockers.
Jackson, beta blockers, yep, ACE inhibitors, yeah, all of those medications can be given, right, if a patient has some heart failure. Okay, is there some reparative we can do also? There's medications and there's rest, but then we also have some non-surgical valvuloplasty. What do you think that is? It's more of a reparative procedure. Now,
Sounds like making a new valve.
not just making a new valve, but if you have some stenosis, some narrowing, what do we do? Kind of open it up, right? Go in and open that up. How would that be done? Like you just go to like a cardiac cath, right? Femoral into the catheter. Yep. Okay. Let's see if this one works. TAVR. Have you heard of a TAVR? Yeah, transcatheter aortic valve replacement. You'll see a lot of these next semester when you go to,
Transcatheter aortic valve replacement, or TAVR, is a less invasive catheter-based procedure. It is revolutionizing cardiac care and reducing the need for traditional open heart surgeries. It's a treatment for aortic valve stenosis. That's when the aortic valve in the heart functions poorly, usually due to calcification, reducing blood flow throughout the body.
We don't take out the valve in the patient. We just move the valve or the stuff leaflets out of the way without having to make a surgical incision at all.
A typical TAVR involves inserting a guide wire into the femoral artery and threading it through the aorta, then around the aortic arch and into the stenotic aortic valve and left ventricle. A common TAVR procedure involves delivering a new valve with a balloon catheter over that guide wire and into the stenotic valve. The balloon is then inflated, opening up the old valve and putting the new valve in place. The wire and catheter are then removed, leaving behind a new functioning aortic valve. Here you can see the new valve opening and closing and able to restore normal blood flow.
Recovery for those patients, especially those patients that are older, is much faster. Most of our patients stay overnight and almost everyone goes home within 48 hours.
Cardiologists at UC Davis Health were the first in the Sacramento area to offer TAVR. They continue to lead the way in providing groundbreaking treatment options to patients with heart and vascular disease.
To have the opportunity to provide a minimally invasive.
How
think about
long,
that. That's pretty cool, isn't it?
how long do they last?
I would think as patients usually get it older age, I would think it would last a lifetime. I don't know, I honestly don't know that I can tell you 100% percentage wise, but. So that might be some kind of patient we take care of, so minimally invasive, right? We don't have to do open heart surgery, the patient can just have that done in the cardiac cath. Pretty cool, I think it's pretty cool. You do some cool. Hey,
Kind of need something just leave.
just leave the old valve, yeah, so there's no. real surgery, right? It just kind of gets right in there. I don't know. How would you think of that? Okay, so that might be something kind of non-surgical, minimally invasive. But then sometimes the patient may have to have a surgical replacement, right? The valve wears and tears. And you can either do a prosthetic or a biologic. Okay, so prosthetic could be what? What about prosthetic or synthetic? That would be like a mechanical valve, right? A synthetic is man-made, right? Or you could do biologic, which is like tissue, and you would use what? Big valve, cow valve. How do you decide which valve to do if you're gonna do more on the mechanical versus a tissue? What's your deciding factor? How long does a pig valve last for? Forever?
Mm-mm.
You know? About 10 years is kind of the average. Okay? Or you can do a mechanical valve, which should last a lifetime. Okay? What is the downfall of having a mechanical valve? Okay, it could fail, but so could a pig valve. Okay. What does a patient have to take the rest of their life? Anticoagulants. Okay? So you could do, usually a patient who gets like a tissue valve, a biological valve, or biological valve, they have to usually take some type of anticoagulant for a few weeks. Okay, but then they can come off those, whereas a mechanical valve, they would have to do differently. I told you that my husband has a mechanical valve, right? Okay, we have the option of doing a biologic or a tissue valve, but why? How many times would you have to have surgery?
Yeah.
Again and again and again, right? Where if you have a mechanical valve, downfalls, you have to check your INR. But it could be in the rest of your life, but that's just, right? Happens, have to take it, check your INR, should be between 2 and 3.
Take it, go through multiple surgeries.
That's what I said, did it while I was young, so then they wouldn't have to, the recovery time is a lot faster too. Anybody know, has anybody ever heard heart sounds for a patient who has a mechanical valve? What's it sound like? Okay, yeah. Click, 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 click. It sounds like a clock ticking. It drove me nuts. I remember after surgery, we're like in one of those little hospital bathrooms, right? It has a tile, like head floor, right? All I could hear was this. I'm like, oh my gosh, this we've ever stood my life. I didn't hear this clicking in my ear, but now I don't even notice it. So if you, sometimes you can hear it, like when you're standing next to somebody, you can hear it. Otherwise, if you put your stethoscope on, you should be able to hear that click, 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 click. Kind of sounds like clock ticking. So interesting. Ask a patient, right? Usually you can see that they have a sternal incision, that they've had open heart surgery for that. All right. Questions on that? Right. All right. You're not smiling now and you weren't smiling earlier. Come on, you guys. All right, let's do some medications.
This is the third semester.
It's the third semester.
We don't smile anymore.
Oh, no, oh, when did the smile stop?
After the first day of the first semester.
Oh my gosh.
But kind of true.
Okay, let's start with one. This is used for a STEMI, ischemic stroke, pulmonary embolism. It is a clot buster. Fibromyelitis. Connective plates. How did you know that? You didn't know it? You just told me you didn't know it. Okay, what is the ending? Place.
Place.
Yeah, place, out to place, tenactive place, right? That will tell you that it's a clot buster. Fibrinolytic, good. All right, Shayla, bradycardia for AV block, it increases the heart rate, it has an anticholinergic effect. C, atropine, yep, we talked about that medication to be given for sinus bradycardia. Yep, and it can also be given to get rid of extra secretions, right? It's an anticholinergic, dries you out. Abby, hypertensive, heart failure, it's an angiotensin II receptor blocker. Yeah, how'd you know that was certain? How do you know that was angiotensin? Because you did, I love it, because I did. Okay, any ending that you looked at? The sartan, right? Your sartans are your ARBs, your angiotensin receptor blockers. All right, Jennifer, this is for erectile dysfunction, can also be used for pulmonary hypertension, it's a vasodilator. Yeah, it's Dalafil. Is it ends in a fill? Yes, good job. So we might not know the meds, but we know their suffixes, so good, L. All right, ventricular arrhythmias, AFib, potassium channel blocker, prolonged repolarization. Kayla.
Amiodarone.
Yes, amiodarone, good job. Yep, common antiarrhythmic medication, so especially for your ventricular arrhythmia. Good. Mackenzie, this is for shock, heart failure, hypotension, vasoconstriction at high risk. You know this one? Not get to that one? Logan, you know that one, Mackenzie, or Logan, you want to help her out? You know that one?
I got E, dopamine.
E, dopamine. Good, dopamine, that's vasoconstrictor. So a patient who's going into shock, remember we talked about cardiogenic shock? Decreased cardiac output. Dopamine might be a medication that helps to increase that blood pressure. All right, angina, heart failure. This is a long-acting nitrate. Mary, what'd you come up with number 7? G? Yeah, how'd you know it was G? It's a nitrate. Any of those end in nitrate? Isosorbate dinitrate. Yes. Okay, so heart failure, long term, right? That could be a long acting, right? You wouldn't give that for a patient. Chest pain right away, right? Prophylactic. All right, number 8, Mackenzie. AFib, hypertension, angina. I put D. The calcium channel blocker, right? D. Still thiazide. Good. Let's see, Marissa. This one is used for SVT, supraventricular tachycardia. Hey, adenosine. We didn't talk about that one yet. What does adenosine do when you give it? Anybody ever had to do it? Supraventricular, fast heart rate.
Stops it and then
Right, you might
restarts.
have a patient who goes into a little asystole, right? And then hopefully it'll go back into a normal sinus rhythm. Patients kind of feel yucky when you give it. All right, last one, severe hypertension, hypertensive crisis. This is a potent vasodilator. Courtney, what do we have? Pace. Nitroprusside, sodium, okay? Hypertensive crisis, I need to lower that blood pressure. Okay, so a vasodilator, right? Not a constrictor, a vasodilator. All right, good job. Did you know those? All right, look at your endings, right? Learn your suffixes. All right. Talk a little bit more. And then we'll do some more activity here. Okay. Talk about heart valves, replacement, treatment. Let's look at bacterial endocarditis or infected endocarditis. Okay, so here's an example of mitral stenosis and vegetation. Okay, this is caused by some type of bacteria, right? So this is a common site for a patient to have vegetation if they have infective endocarditis. Okay, so what's happening in endocarditis? Infective. Yep, we've got infection, inflammation, right? So some type of bacteria, right, is entering the body, right? And it's gonna kind of settle into that lining of the valves of the heart there. And it's gonna cause an inflammation, inflammatory response. And then you have all this like fibrin, particles, bacteria that kind of sits there in the heart and in the valves, okay? And then we have this vegetation that can grow there, okay? Do you think that's good for the heart valves? Yeah, right? So it can grow in on that heart valves, and over time, it can cause problems with the heart valves, right? It can cause them to either damage, right? They can have some scarring, some stenosis, and they're not gonna close properly. What can also happen with this vegetation that can form in the heart? Kind of sitting there in the valves, and what happens? We've got blood's kind of flowing through there. Got some vegetation growing there. It's spread, right? So particles can travel, right? Emboli, where do you think they can go? All different parts of the heart, of the body, right? Okay. So I'll come back to that, right? So a bacterial endocarditis. So some type of, usually bacterial, right? Causes that infection of the endocardium, so the inner lining of the heart, that inner lining of the heart, and it can also cause damage to the valves. Who's at risk? Who's at risk for infective endocarditis? IV drug use is a big one. Patients with valve replacements, okay, or other cardiac defects are at risk for it. If I had a bacterial infection, what would be some of the signs and symptoms I would present with? Any type of bacterial infection. Fever is a big one. Chills, fatigue. Okay. It can affect my heart and my heart valve. And if it's affecting my way that my heart valve, either it has some scarring, has some changes in the valve, what might I hear when I listen?
Murmur.
Murmur, yeah, murmur. Can cause that patient to go into heart failure. Some patients with infective carditis have petechiae can form. All right, so this is just kind of a pathophysiology map, right? You have some type of infection organism. It causes vegetation. It's got fibrin, platelets, leukocytes that are kind of all in the inner lining of the heart, along with the valves. Okay, it can cause valve damage, right? If we have valve damage, we could lead to heart failure. If we have a bacterial infection, it can lead to sepsis. What is sepsis? Systemic infection. So how do you treat it then to prevent a systemic infection? Antibiotics, right? So yeah, our patient's gonna be on antibiotics. So we're gonna be on antibiotics to heal that. Is that like a 2-day course, week course? How long
No.
are we talking?
Why?
4 to 6 weeks? Okay. Remember that this vegetation that you talked about can break off, right? You can have emboli, right? That could go to the lungs, it could go to the kidneys, the spleen, the brain. So a patient comes in, right? They've got some fever, some chills, a murmur. Before we give antibiotics, what are we gonna check? Blood cultures, right? We always want to get blood cultures before we give antibiotics, no matter what kind of infection, right? And then we're gonna treat it with long-term antibiotics. One thing I also should mention that when I talked about the heart valves and infective endocarditis, if a patient has any type of valve issues, mechanical valve replacement, what do they need to do before they have any invasive procedure, especially dental work? Yep, they need prophylactic antibiotics, right? There's a lot of bacteria in your mouth, right? And that can go right into the bloodstream, go right to that heart, cause problems with your valves. When my husband had his heart surgery, they made him get his wisdom teeth out. He hadn't got them out yet, had to get them out before he had heart surgery. Because again, all that bacteria in your mouth, right, can go right to the heart and cause damage. Okay, so prophylactic, goes to the dentist, has to take prophylactic antibiotics before he goes, right, just to prevent any infection. So blood cultures, antibiotics, 4 to 6 weeks. So we're gonna put a peripheral IV and call it good. Gonna do long term, right? Pick line. Can patients have to stay in the hospital that whole time? No. Patients can come in. They can do antibiotics at home, a home health nurse can come in, maybe an ER or infusion center. Does not mean that patient has to be. Sometimes it does damage the heart, so the patient will have to have a repair of their valve. New infection. All right, let's take a break. It's 10:05. We'll come back at 10:15. Here it's not. Frequency and abdominal, thoracic that we're gonna cover. What is an aneurysm? Not a blood clot. Stretching, right? A stretching of that vessel, right? What happens when it starts to stretch? What happens to the lining? The weakening, right? The lining starts to weaken, and then over time, if it's weak and it starts to get larger, what can happen? It ruptures, right? Okay. So, we have dilation, right? Localized dilation of an artery. Okay, so the ones that we're gonna focus on are your aortic, or your abdominal aortic and your thoracic. What causes it to be weak? Hypertension. Yeah, hypertension is a big one. Yep. Yep, hypertension, and then, atherosclerosis, right, poor diet, coronary artery disease. All right, so AAA, right? Have you ever heard of AAA? Abdominal aortic aneurysm, not the people that come help you in tell you, right? This is abdominal. Okay, so usually it's detectable when it becomes larger, dilates about 5 centimeters in diameter. How do we check that? How do we know that it's dilated? What would be that test usually done to check for these? Ultrasound, and then usually do a CT to confirm it. Yeah, so a CT, right? Patients can live with it, right? But if it starts to get larger and larger, and then there's a risk for rupture, what could happen? You would die, right? You would die, right? Because now all your blood is not perfusing to the rest of your body, right? Okay, so patients who have an abdominal aortic aneurysm tend to have some gnawing pain around the abdominal area. Sometimes they can go to the back. Sometimes if the patient is thin enough, you can actually see some pulsations in their abdomen. Again, if it's the rupture, right? Severe pain when it ruptures. Right? Obviously you don't want it to rupture, right? But if it would rupture, they're gonna have pain, but then what else kind of signs and symptoms are you gonna have as you're assessing them? Right, our blood pressure is gonna go way down, right? Looking after breathing, heart rate goes up, right? Make a little consciousness, you think? Absolutely. Okay, so unless you are like right in a hospital setting, most patients are gonna die of their rupture, right? Right. Hypovolemic shock. What else have you seen? If you're bleeding into the abdominal area, what else did you notice? Distended abdomen, right? And you're gonna see some changes there with that blood pressure going down. Okay, is there a way to prevent it from getting larger? Yeah, control blood pressure, right? Make sure there are medications, right? You're doing probably your ECTs, right? Checking it out. If it starts to get larger and larger, what else could you do? You're gonna try to control it from getting larger, but then what happens? What other might you need to do? The surgery. Yeah, but what's the surgery gonna do? Close what? Just kind of, remember the outside walls are kind of stretched, like we need to do around that area. What's that? Reduce the stretch. Okay, how are you gonna do that? Kind of put some kind of graft in there, right, around that area, kind of hold it so it doesn't stretch and rupture. Yeah. Put kind of graft, kind of put a graft around that area. Good. I think I have another, I don't. Let's talk a little bit about thoracic, right? I want you to know about thoracic too. What kinds of signs and symptoms might a patient have when it comes to a thoracic, right? If they start having aneurysm that gets a little bit larger. What's that? Chest pain, yeah. What else do you think? Shortness of breath, difficult swallowing, yep. Okay. Yeah, might have some hoarseness, right? Think about where it's located, right? In the chest area. Okay, so we would do a CT to check that. Right, same types of interventions. Right, control the blood pressure, monitoring it. If it would rupture, we would we see some hypovolemic shock? It should kind of depend on where it's located. All right. Pericardiocentesis. What is happening here in a pericardiocentesis?
Draining the pericardium.
Right, we're draining the fluid out, right? That's putting pressure on that heart. So a pericardial needle is put into that pericardial space. Catheter is inserted there, you can kind of see that picture, and then, that fluid is drained out that. Why do we need to do this? So who gets a pericardiocentesis? What would cause to have extra fluid there? Pressure, yeah. Yep, we do that pressure. So a patient who has a cardiac tamponade, like we're talking about now. If there's any type of like chest infection, chest trauma, can cause some extra fluid to be around that heart there. Called a pericardial infusion, so there's extra fluid around that heart. Okay. What happens if we have that extra fluid around that heart? Why is that a problem? What's that? Works harder, right? And isn't able to contract as well. Yep. So cardiac tamponade or acute cardiac tamponade, right? That's when you have a small amount of fluid that accumulates in that pericardium. Okay. And we're going to have a decrease in our cardiac output. Okay, so this might be a reason why a patient has a pericardiocentesis. So if you have that extra fluid around that heart, again, the heart sound will kind of be muffled a little bit. The heart's going to work harder, right? So our heart rate's going to be elevated. We're not perfusing as well, so what do you think our blood pressure is going to do? It's going to drop, right? We're going to have some hypotension if you've got decreased cardiac output. So in this case, we might have to give them some fluids to increase their cardiac output, and then obviously a pericardiocentesis to remove that fluid around that heart that's causing it to not contract as well. All right. Anybody heard of cardiac rehabilitation or cardiac rehab? What is the point of cardiac rehab? Strengthen the heart. Okay. How is that done? Who gets cardiac rehab? Yep, heart procedures, heart surgery, valve surgery, open heart surgery, cabbages, right? What is the point of it? It says physiological, psychological, mental, spiritual, economic, vocational. What does that mean? Why would they get that? My husband went to cardiac rehab after his heart surgery. Why?
Hard on the
I don't know if
body
he's normal.
and mind.
As close to normal as possible, right? So he went to the hospital, to the clinic, and they put him on a treadmill and said, start walking. Why?
Heart starts pumping.
Get her going, they had him hooked up to Kelly. Make sure things working, right? Is the heart doing what it's supposed to be doing? Are we overdoing it, right? Trying to get your patient back up to their baseline, right? But we don't want to overdo it, right? We don't want them to cause trauma, right? What else? Why psychological? Because guess who's running that cardiac rehab?
People who've been through it.
Who's running? Who's monitoring it? Nurses. Right? Could you meet other people who've also gone through heart surgery? Could that be psychologically, mentally, been able to see others? Do you think some patients are scared after having a heart attack? And now don't wanna do anything, scared to exercise?
Yes.
Could that be a psychological problem? Okay, would that be okay to have that nurse reassuring that patient, I'm monitoring you, will stop if it starts to cause pain? Okay, how about spiritual? That's important to some patient. Okay, how would you incorporate that? Chaplain come? Or they want to do prayer, right? Okay. Some patients might be off of work. Could there be other people you could contact, maybe patients having other issues? Economic issues, work issues. Who else could you involve? You're the nurse. Social work, right? Think about you're the lead, right? What else can you get involved? It can be outpatient or it can be home-based. Outpatient, I think is better, right? Getting involved with other people, monitoring it. Is there education that you could also do with your client? What education would you do? What's that? Diet? Absolutely. What else?
Monitor for signs and symptoms.
Signs and symptoms, yeah, what to watch for. Exercise, diet, healthy lifestyle. If you're smoking and had a heart attack and still smoking, could you get some smoking cessation? Okay, emotional support. All right, I just threw this in, just a little bit overview. I think I have on a sheet that I gave you with the heart failure. Okay, jot down a few things. Peripheral arterial disease versus peripheral venous, right? The overlying like umbrella term is peripheral vascular disease, right? But it can be an arterial problem or it can be a venous problem. Okay? What do you guys remember? What was that class? Health promotion? What happens in utero for neonatal circulation? Are the babies breathing through their lungs?
No,
Where
umbilical,
do they get their oxygen from?
umbilical cord.
Umbilical cord, right? Okay, the oxygenation occurs in the placenta, okay? Do you remember learning about the baby has 3 shunts that are in place during utero? Okay, what do these shunts do? They're temporary shunts that should close when they are born, right? When they through delivery. Right, we learned about those shunts, ductus venosus, right, bypasses the liver. Ductus arteriosus bypasses the lungs of the baby, right, and foramen ovale, right, bypasses the lungs, right, those should all close once the baby is born, okay, because the babies get oxygen through that placenta. Okay. So when we talk about a patent shunt, what does that mean? So after the baby's born, the baby still has a patent shunt.
Still there.
It's still there, it's still open, right? It should close first couple of days after birth, but some patients can have a patent shunt and it's kept open. Okay, all right, congenital heart disease, what does that mean? Born, yep, okay. So, around 8 to so live births per 1,000 live births can have a congenital heart disease. Okay, a lot of them are asymptomatic. Maybe at birth, and then after the first year of life, they develop some symptoms. Most common anomaly that we'll talk about is a ventricular septal defect, a VSD. And then babies who are born with trisomy like 21 often have increased risk of heart disease or congenital heart defects that have to possibly be repaired. Okay. What do we do? Anybody who's worked OB or wants to work OB, what do the nurses do before the baby is discharged home to check for any congenital heart disease? What do they do? A simple, easy little procedure that the nurse can do. What's that?
Listen to it.
You can listen to it, yeah, but what else? It's an easy little procedure that we do. Everybody gets it done usually after the first 24 hours of life before they go home. It feels good one.
Oh, yeah.
Put a little pulse ox on my arm, hand,
And then
Right.
on the
and on the foot.
and they have to be within like 2 of each other.
Right, they have to be within 2 of each other. Usually they say 95 or higher, they have to be within 2 of each other. Right? It's a quick, painless way to see the baby might have a congenital heart defect. Is that gonna catch everybody?
No.
No, but it might be something to look at. So that every baby needs to have that done before they go. Pulse ox reading. Look at the O2 sat. If a baby did go home, maybe they didn't notice it, what could be some signs and symptoms that maybe they're having heart problems?
Slow feeding.
Slow feeding,
Fewer wet nights.
sweating, diaphoretic, not gaining weight, more irritable, more sleepy than usual. Yeah. Might even have some bluish discoloration to the skin, right? Some cyanosis. All right, so what I want you guys to learn for this one, the disease processes can be broken up into acyanotic and cyanotic. So what does that mean, cyanotic? Yeah, they're gonna have bluish coloration, decreased oxygenation. So we're gonna cover tetralogy of Fallot. That's the only one that we're gonna talk about in the cyanotic. Okay, acyanotic then, what do you think that means? And that there's no changes in in color of the skin, right? There's no decrease in oxygen levels in the blood. Okay, so we're gonna talk about atrial septal defect, ventricular septal defect, and patent ductus arteriosus. Okay, so those are kind of the ones we're gonna cover. It's considered acyanotic. It has increased pulmonary blood flow. What does that mean? What's that? Yeah, more blood back in the lungs. Okay. Whereas cyanotic, decreased pulmonary blood flow. Okay, less blood flow to the lungs. Okay. So like I said, we're talking about acyanotic versus cyanotic, and then it can be based on shunts, left to right, right to left. So your left to right is your acyanotic. Okay, your right to left are your cyanotic. So let's look at a PDA to start with. What does PDA stand for?
Patent ductus arteriosus.
Yes, patent ductus arteriosus. So in utero, right, this was open, so we could bypass the lungs, right, from the pulmonary artery to the aorta. But after birth, we want that to close. Okay, but it's patent. So when we say patent, it means that it's open. Okay. Usually should close within the first couple of days of life. If it doesn't close, what's happening? We have extra blood flow that's going into the lungs. What do you think you might notice in a baby who's got extra blood flow into the lungs? Crackles, shortness of breath, not eating as well, therefore not gaining weight, respiration rate, to be on the up or down. Up, yep. Working hard to breathe, right, fatigue. Okay, so there's different treatments, you can watch and wait, sometimes if it's not causing any problems, they'll just see if maybe they'll grow into it, it'll close on its own. Sometimes they'll do a medication, indomethacin. Right, that is what kind of medication? Class that is, an NSAID, yes. So an NSAID to help close that. Or they might have to do cardiac catheterization. What would that do? Why would we do a cardiac cath? What would we be doing when we went up into the heart? What do you think we would do? There's a hole.
Was it?
Let's fix it. Let's plug it. Let's put a graft in, a mesh graft or something, right? If it's causing any problems. And usually it can be done cardiac cath. It wouldn't have to be open heart surgery. Okay. All right. ASD, what does that stand for? Atrial septal defect. Yes, what does that mean? There's a hole in between the left and right atrium. Okay?
I had that one.
Did you? Did you have surgery? Yeah. So we have that kind of blood flow going extra into the lungs. Again, patient might be short of breath, tired, arrhythmias, not eating well, not gaining weight. Okay. So sometimes it's small enough, it might close on its own, or they might have to have surgery to repair it. Did you do cardiac catheterization? Cath?
I was 2 years old.
You don't remember?
No.
You don't remember, like it's yesterday. How does that differ from a VSD then? Ventricular, right? So that means what?
Hole between the ventricles.
Ventricles, right? So we have an opening there. Okay? So we can have extra blood flow into the lungs, and sometimes also, that left ventricle might be enlarged over time. So again, poor growth, poor eating, murmur, right? With these, a murmur can often be heard, right? Respiration rate might be increased. Patient not growing like they should. What would we do for treatment if we're not gonna do surgery right away? And do some diuretics, right? If they've got extra fluid in that lung, right? Probably breathing. All right, so those are the acyanotic, right? We have good blood flow to the lungs, right? But now I want to talk about cyanotic. Okay, the one I want to talk about is pathology of flow. That's what we're gonna focus on. What does tetra mean? 4, right? So this has 4 different abnormalities when the heart is formed. Okay, you do not have to memorize these or know these. But they have pulmonary stenosis, they have ventricular septal defect, they have an overriding aorta, so the aorta is out of place, and then their right ventricle becomes large. Okay, so 4 different conditions that occur. Not enough blood flow gets to the lungs, right? So we have poor oxygen saturated blood. Okay, so the client is going to be cyanotic. When did it become cyanotic? What would cause that heart to need to pump more, need more oxygen? Feeding,
Crying.
exercising, crying, right? Any of those things that's going to increase oxygen demand. Think about if it's a baby, right? Crying, babies cry all the time, right? That's how they communicate. So crying, feeding. As an older child, again, exercise if you have a toddler, okay? Respiration rate will be elevated, heart murmur, fatigue, or weight gain. Okay. So what do we have to do for this? What's the only way to kind of prevent it? Yeah, they'll have to have surgery, right? Have to surgery to have to fix all those spots. Okay. Babies will have what we call, or children will have what we call TET spells. What does that mean? What's happening? Yeah, they'll become cyanotic. So the top page, right? Child with pathology of flow has bluish skin, right? So we have some cyanosis in the extremities around the mouth. And they can develop TET cells. Again, the body needs more oxygen. So here's the treatment. You're at home, you teach the parents. If a baby starts to have a TET spell like that, what are we doing? Knees to chest. What is that doing? Get the blood back to the heart. Yeah, get back to the core, back to the heart. That child is an older child. What are they doing? Squatting. Same type of thing. I'm not gonna do it because I probably won't get back up, right? Same type of thing, right? It's helping to shunt that blood back up to the heart. Back up to the lungs and to the heart, right? So repair. If you're in. Can babies have heart failure? We just talked about this, right?
Yes.
Babies can have heart failure, so we're gonna be monitoring their weight gain, we're monitoring their respirations, their heart rate. Okay, How are they perfusing? They can have the same type of manifestations as an adult. Will feeding be a little bit different?
Yes.
Yeah. Okay, might take longer, right? Less, smaller amounts, maybe more frequently. Okay, if you have a baby with severe heart failure, they might have what placed if they can't take everything oral?
Feeding tube,
Yeah, feeding tube, an NG tube, right? So they'll let them feed on their own, and whatever they don't take,
put it
they
through the
can go
tube.
through their nasogastric tube. Okay. Some of these babies are on higher calorie formulas, right, to help with weight gain. Okay. So especially if a patient has heart defect and they're waiting for surgery, we want to get them growing, right? We want them to gain weight so that they can go and have their surgery. Babies can take medications, right? Lasix. The Jackson, we talked about that one. And what did we say our parameters were for holding for an infant?
Under
Less than
90.
90. How about a child? Under 70. Okay, so teaching those parents signs and symptoms of heart failure. If they notice that the baby's not eating as much. How would you know if that baby has dehydration?
Wet diapers.
Right, look at those wet diapers. Tears after 3 months, yep. Decreased drinking. Okay. All right. Last two, rheumatic fever and Kawasaki, the last ones I want you to be familiar with. Rheumatic fever, so an inflammatory disease process that happens, right? It can, when we have a disease, this inflammation, it can cause inflammation of the joints, subcutaneous tissue, the heart, right? What is it most often caused from?
Untreated stress.
Yep, untreated. Yep, untreated or maybe not partially treated, group A beta hemolytic streptococcal pharyngitis, right, strep infection. Okay, we don't tend to see it too much in this country, because we're pretty good about our antibiotics and our vaccine, right? Child has a sore throat, maybe fever, stomach ache, we can do a quick strep test. Okay. But see it more often in developing countries. Okay. What we have to be worried about is that it causes some valve damage, right? We don't want any valve damage to occur, okay? So a patient might have some symptoms. They might have some arthritis, so their joints become very red, tender. They can have some carditis. So we might have a murmur, we might have increased heart rates. They'll have some chorea where they have some involuntary jerky movements, a rash, abdominal pain, fever. Okay, but we really want to prevent any damage to our heart valve. And that's really what can happen when you have that rheumatic heart disease. Okay. So what do you think we would do for treatment? All right, we have to do antibiotics, right? Because if we have strep infection that wasn't treated.
Treat.
We want to give that. So penicillin, if they don't have an allergy, right? Do a strep culture. Penicillin, usually do IM. What else can we do for inflammation? Yeah, like what? Tylenol is an anti-inflammatory. What's an anti-inflammatory? Corticosteroids? You do NSAIDs like your aspirin?
Yeah.
Right, we never say we want to give aspirin, right? We would say Rye syndrome, aspirin, right? But for these two, rheumatic fever and Kawasaki, will sometimes be on aspirin. Okay. Do these children need to be on prophylactic antibiotics?
Yes.
How long? Sometimes forever. Sometimes it's, I think the book talks about 10 years or until you're 21. It kind of depends on every patient. I remember a coworker, her son developed rheumatic fever, had a strep infection. He had to take, I think he was taking, he was taking penicillin or something twice a day. I remember every morning she'd call, take your medicine, take your medicine. Right, so think about that. Every day, for 10 years, the rest of your life. The book talks about giving an IM injection too, the little book wasn't good. Okay, but we don't want to have any damage to our heart valve. Okay. All right, last one, cholestasis, what's happening here?
Abnormal immune response.
Yeah, abnormal immune response, yep, so the patient is febrile, they have this rash. Okay, and they have this vasculitis, okay? Unknown, some type of infection, but often they don't know. Okay, this again is serious because it can lead to coronary artery aneurysms. Right, we don't want that to happen. Okay, usually happens in children less than 5. And it kind of goes through some phases, some things that you might see in here, some common signs and symptoms. So in the acute phase, they have a fever, and it's a high fever, and it lasts usually for 10 days. Okay, conjunctivitis. The skin becomes very red. You can see their hands become swollen and red, palms of the feet become red. Okay, their lips become dry and cracked. Strawberry tongue. I don't have a picture of that, but it's very, yeah, very red, right? Like a strawberry. Alright. Then after those 10 days, the patient starts, the fever is not there, right? And they start to kind of feel a little bit better. Their hands, feet peel. And, they might have poor appetite. And then the last phase, convalescent phase, is when all the symptoms are gone. And so it usually can last up to like a whole month, but the patient is not feeling the greatest. What is our treatment? Prevent coronary artery aneurysms. What do you think we would treat it with? IVIG, yes. What is IVIG? Yeah, your antibodies. Yep, your antibodies. We want to start that sooner than later. That's going to help prevent it. Yep. What else did I say that we might give them? After. Or corticosteroids, something anti-inflammatory. So not the most common things that you see, but again, if not treated, can cause some cardiac issues. And we don't know over time to cause an aneurysm of coronary arteries, because that can cause other problems like MI, right? Heart failure. All right, good. All right, I have one last activity for us to do.